It's a really tricky question. I think a lot of health plans use risk stratification tools to help them identify members at the greatest risk. In our plan, we currently use a methodology of 11 or more controlled substances written by 4 or more providers or filled by 4 or more pharmacies. And we are looking to change that into a more risk-based criteria where it's not an arbitrary number of prescriptions or providers, more a combination of things that put a member at greatest risk for either an overdose or some other concerning event. So we're looking at combinations of opioids and benzodiazepines, gabapentin, stimulants, skeletal muscle relaxants, and then combining that potentially with not just the number of opioids that they're receiving, but their milligrams of morphine equivalents, which has been shown in the literature to correlate to overdose events. I think it has to be. So you can't just assume that the criteria will be a one-size-fits-all for everybody. So I think you have to take into consideration if you have a beneficiary who recently is started on addiction treatment or had a significant change in their medical history, so recent diagnoses of cancer, things like that. I think you have to give those members a little bit more time before you put them into a program to see what their long-term treatment plan will look like.